The human body. That is what the foundation of this class is, right? The human body, anatomy, physiology, pathophysiology, and treatment. That's all you have to know here. So let's dive into it. Anatomy and physiology. You can't understand the function of the body, body systems, unless you understand the anatomy that is the basis of it. Let's use an example. I can't effectively evaluate my patient's sprained elbow, maybe possible sprained elbow, if I don't know what an elbow normally looks like, and I don't understand what the normal range of motion is for an elbow. I can't evaluate my patient's injured joint if I don't understand the anatomy and the function of that elbow. Everybody's elbow is a little bit different, right? My elbow's different than yours, and then an injured elbow can certainly be different, but your patient could have a condition that limits the mobility of those two hinge joints called elbows. So what do? We compare one side of the patient to the other. So we compare their good elbow that works right, and that can give us an idea of how the other one should work. And then we can evaluate from there and treat from there. Let's see, symmetry. It's important to compare things from side to side on our patients. In general, things are pretty close to the same from side to side with our patients. I'm not talking about amputated arm from 10 years ago. Obviously, that's not going to be symmetric with the non-amputated arm, but just a normal patient, we can compare one side to the other. How do I know if my patient has swelling and deformity to their right knee? I'm going to look at their left knee and compare it to see if it looks like the right knee swollen, the left knee's the uninjured one. Oh, they look way different. The one on the right is really puffy and it's red, and the one on the left isn't. So that's what I'm talking about. That's really important. The body is broken down into systems. Well, actually, it works together as one big system, but the functional parts of the body, that one big system, you have smaller systems like the digestive system. That's one system, and it has its structure and function. And then let's say the respiratory system, it has its structure and function. Cardiac system, there's interconnection between all of them necessary to keep a person alive, keep them doing well, but it does break down into systems. And we learn in this class, we'll present material in chapters, and we'll have one that is over the respiratory system and respiratory emergencies, then cardiac system and cardiac emergencies. So it breaks down that way, everything working together to keep human alive and keep that human living, breathing, and functioning properly. We call that homeostasis. Homeo meaning human, stasis means our Texas definition, staying the same, right? Homeostasis, human staying the same, human properly functioning, and with all body groups working together to maintain life in that human. That's what our goal is, to help restore and maintain homeostasis. Pathophysiology. What is that? Pathophysiology is, I don't even like this definition they have. I'm going to give it my own. Pathophysiology is it's the disease or injury process and how that disease or injury impacts the body or a system within the body. They have respiration and perfusion there, but I think that's wrong place to throw that in there. I did not make this slideshow myself, but I can criticize it and critique it and try to clarify it. But normally in the classroom, I would just be at the whiteboard writing and talking. We can't do that. So here we are. As I said, you have to have a good working knowledge of anatomy. This is not an anatomy class, nor is it a physiology class. So you learn pertinent parts of anatomy and physiology. I'm not going to give you a blank diagram of a skeleton and ask you to label all the parts, but we are going to learn the minimum necessary anatomical parts, the landmarks in the topographic anatomy of a person and how all that relates to injuries. But I'm not gonna have you sit down and write the Krebs cycle for me. I'm not gonna have, there's a lot of things I'm not gonna have you do. We're gonna break it down into bite-sized chunks so that you can ingest, digest, and internalize the material. Superficial landmarks, what would those be? Everybody take your hand, find your right ear. Behind your right ear, there is a bony bump that sticks up. That is called the mastoid process. That is a superficial landmark. It is a very important landmark. We'll learn in a few chapters that someone with a basilar skull fracture can have Battle's sign. That's apostrophe S. Dr. Battle's sign is bruising around that mastoid process, and then raccoon's eyes around the zygomatic arches, that lower part of your orbit, having bruising there, also called ecchymosis. That is another indication of a basilar skull fracture. So that topographic anatomy is important. It is an important way for us to convey information to other clinicians and help paint that verbal picture or that written picture of what we see with our patient. And again, that all ties back to that continuity of care, providing the best care for your patient and allowing the next clinician to provide the best care for the patient. Let's hit some topographic anatomy here and some, I like this picture better than the one 3 slides from now in the book because this looks like a real human. We have planes in the body. Note that these lines intersect somewhere right in the middle of his belly, kind of, right? What do you suspect might be behind there? You might say belly button. From now on, it's not a belly button to you, it's an umbilicus. Unless you're talking to your patient and you say you got some bruising around your belly button, how long has that been there? If you say umbilicus, I'll know what you're talking about. If you say umbilicus, my wife who's a nurse, my son who's a paramedic, they'll know what you're talking about. My daughter who has a degree in musical theater and teaches music in elementary school, she may or may not know what an umbilicus is. She probably does because growing up in this household, but that is an umbilicus. That's where these things intersect. So transverse plane, that's easy, goes across, right? Transverse, so it goes side to side through the umbilicus, and it does something really cool as far as landmarks. It divides the abdomen into quadrants, right? Right upper quadrant, left lower quadrant, right lower quadrant. Knowing what you know coming into this class, if I tell you that I have a 17-year-old male patient with nausea and vomiting and pain in the right lower quadrant, you might already know that that right lower quadrant pain could go with appendicitis, because that's where the appendix is located. If my patient has bruising and swelling in the right upper quadrant after blunt force trauma, somebody whacked him with a 2x4 right up here in this right upper quadrant, man, let's see, is there an organ that sits up there? Sure is. We call that sucker a liver, and it is like a big blood filter. We'll learn a little more about it than that, but today it's a big old blood filter. It has a rich blood supply because it has an important filtration job to perform. And if you get whacked in that sucker with a 2x4, it could cause a tear and cause it to start bleeding. And we're going to see discoloration and distension there possibly that gives us an index of suspicion. New term for you. We'll build on it in a few chapters, but gives us an index of suspicion that Mr. Dude here might have internal bleeding from that liver, which can bleed a lot. You can bleed out quickly from there. So that quadrant thing, that's important, right? Left upper quadrant, stomach, part of the colon, spleen, that's another blood filter. It's up here, tucked just under the edge of the rib cage and slightly down into that left upper quadrant. 2 whacks with a 2x4. Got him over here in the right upper quadrant in the liver, got him in the left upper quadrant in the spleen. Mr. Dude here could die quickly. We have to recognize that. We have to convey that information quickly to the hospital, and they may even go ahead and call a trauma alert and have the trauma surgeon and the surgical team on standby based on our communication. So it is very important. These are things that you have to know to assess and treat your patient and communicate your patient's condition to other clinicians. Okay, coronal plane. We're not talking the disease. We're not talking the drink. Coronal plane, that slices. If this guy went through a big bandsaw and it cut him into front and back, or anterior and posterior, the coronal plane would do that. That more comes into play in surgery and that kind of stuff. Sagittal plane. Oh, yeah, because just my transverse plane, that didn't give me quadrants, did it? I jumped the gun, right? I'd like to say I did that on purpose for effect so I could reiterate it here, but I just got ahead. All right. Transverse plane, that's easy. Sagittal plane divides our patient into right and left. That goes through the vertex of the skull, or the crown of the skull, and right through that big old table saw. Man, we got a big old blade on this sucker that could slice one of those giant redwoods from the sequoia forest, and it slices Mr. Dude into right and left. So he has a right orbit and a left orbit because of that sagittal plane. He has a right upper quadrant, left upper quadrant, and it goes right down straight through the pubic symphysis. That's where the 2 pubic bones come together in the front, right down the middle of the sacrum in the back. So that is a sagittal plane. That and the transverse plane, they do a lot for us. That, I'm glad somebody did that, so we have landmarks and we can identify what, in a standardized fashion, what's going inside our patient. Even surgeons use this. So it's important that we master that. You already have. That's cool, right? Anterior toward the front, posterior toward the back, dorsal and ventral. Oh man, dorsal and ventral. If you've ever fished for catfish, they have a big old dorsal fin that will cut the heck out of your hand if you don't handle it properly. So think about that fin on the back of a fish. That is the dorsum or the dorsal aspect. Then ventral would be that face, neck, chest, abdomen, front side of the pelvis, all that cool stuff. That's dorsal and ventral. Oh man, but then your hand has a dorsal aspect and a palmar aspect. Dorsal aspect is on the back of the hand. But wait, you say, when I'm standing facing somebody, if I have my arms down to my side, I may have the back of my hand pointing toward that person. We use anatomic position in medicine. There's a good old guy named Da Vinci, I think, who first drew this. He drew a naked man. Don't know why he did that. His medicine. He was quite an amazing guy, but he drew the person with the palms facing forward. That is anatomic position. Why is that important? One thing, if you were to x-ray Mr. Dude's arm in anatomic position, the ulna, which is on the pinky finger side, it would be straight in alignment with the pinky finger. The radius, which is on the thumb side, it would be straight in line with the thumb. If you rotate it around, you get the bones kind of crossed up. And if you're doing x-rays, you don't get as clear of a view. So that is the standard thing, anatomic position. Medial is toward the midline. We take that sagittal plane, and anything that's toward that midline would be medial. The opposite of that is lateral. So let's say Mr. Dude has some stab wounds, and he has a stab wound 1 centimeter, and we're going to use his right and left. He has a stab wound to the right upper quadrant that is 2 centimeters superior toward the top of his head, and 2 centimeters superior to the umbilicus, and 2 centimeters lateral to the umbilicus. Okay, we've kind of pinpointed it right there. And then he has 5 gunshot wounds lateral to the stab wound, also in the right upper quadrant. So that kind of gives us a direction of things. All right. Distal and proximal. Let's use this extremity. This is you thought this was a right leg. This is his right lower extremity. And everything that's closer to the beginning of that right upper extremity is going to be proximal. So the greater trochanter, which is that knobby prominence on the outside of the pelvis there at the head of the femur, everything closer to that would be proximal. But if he has 10 centimeter laceration that is 18 centimeters distal to the greater trochanter, maybe it's going to be down in here. So distal would be away from the origin of that extremity. Proximal is closer. And same with the upper extremity. You used to think it was an arm, right? So proximal would be closer to the origin of that limb. Distal would be down toward that fingertip. And proximal could also be toward the midline. So that helps paint that word picture of what we're doing. Superior would be toward the top of the head. Inferior would be toward the foot. So I think we covered them all. Okay. Another picture of it, if that one was too busy for you, transverse plane right through the umbilicus. Sagittal plane divides into right and left, and then coronal plane front and back. Skeleton keeps us from being a blob of muscle and tissue and organs hanging out on the ground and trying to ambulate like an amoeba. Instead, it gives us our human form, and we can stand erect and walk because of the combined function of muscles and bones and connection with ligaments, tendons. So what in the heck are ligaments? Ligaments connect bones to bones, tendons connect muscles to bones, cartilage is a gliding surface that lines like hinge joints, ball and socket joints, that provides that gliding surface so we don't build up a bunch of heat and wear it out because we got it too hot. Okay, and so that it moves smoothly. What I usually do at this point is make a muscle with my arm and say I pulled the distal part of my right upper extremity proximally up toward the shoulder to make my big old bulging bicep pop up, right? Did my lower arm push toward my upper arm with that hinge joint so that I can make that big old muscle? No, my bicep contracts, and that's what causes the movement. Muscles don't push, muscles pull. So that, and then as I extend my arm, my tricep is contracting and straightening my arm out. The opposing muscle helps control how quickly that moves back and forth and might help kind of counterbalance to make it go smoothly. But the work is done by the muscle pulling. All right, enough of that. Axial skeleton. That is, let's do it the other way around. Then we'll come back. Yeah. Appendicular skeleton. That's your arms and legs, right? Which now we know are upper extremities, lower extremities. That is, and including your pelvis. That is all the bones, all the tendons and ligaments, all the cartilage that comprise the upper extremities and the lower extremities. That's the appendicular skeleton. So what in the heck is the axial skeleton then? It'd be everything that ain't the appendicular skeleton, right? Skull, spinal column, thorax, that's all axial skeleton. Why didn't I put abdomen? The abdomen ain't made up of bones. There is a spinal column going through there, but abdomen itself is anterior to that spinal column, and it doesn't have bones in it unless you chew up chicken bones and swallow them when you're eating. I don't know, unless you're ingesting bones. All right. Bunch of bones in the head, right? What is the function of those? Number one is to protect that brain that's in there. Things that we need to start to be familiar with, things that are landmarks. Frontal bone or frontal skull, that is here. Orbits, these aren't eye holes anymore. Those are orbits. It takes bone from part of that frontal skull, that frontal bone, plus some of the face bones, such as your maxilla, to create that orbit that the eye sits in. These little holes up here in the forehead, nerves come through those holes and down on the chin. It's called a foramen. Somebody with a fractured mandible or jawbone, maybe they're having numbness and tingling in their face on one side because they have a fracture and they have swelling that's starting to interfere with nerve impulses traveling along the nerve that goes through that little mandibular foramen. The big thing here, foramen magnum, that is the hole in the base of the skull that the spinal cord, where the spinal cord exits and then moves along the spinal column. Very important, by the way. Okay, temporal bone or temporal skull. Occipital bone back here, that's that bony part in the posterior skull. Spinal column, I don't think I'm going to ask you how many vertebrae are in the spinal column. It would be 33. What's important for you to know? The cervical spine up here in the neck, right? And with vertebra, we assign them a name. Its full name would be, let's say, the 7th cervical vertebra, but we're lazy, so we just call it C7. So tenderness at C7 is going to give you an index of suspicion that your patient might have a cervical spine injury. We don't want to paralyze them, so we're going to take appropriate precautions in handling them, patching. Good Lord, I never had trouble saying that word before. Packaging them and transporting them to the hospital. T-spine or thoracic spine. Posteriorly or in the back, the ribs articulate or connect to the thoracic vertebra, and then those ribs go around the fixed ribs. We'll talk about those in a minute. They articulate anteriorly with the sternum, right? When you do chest compressions, and people who aren't as informed as you guys, they think they're breaking every rib in their patient's chest. It is possible to break a rib doing chest compressions. For the most part, what you feel is there's cartilage called the sternocostal cartilage that connects, that's between the sternum and the rib. Anything costal has to do with the rib. What's happening when you do a chest compression is that connection of between the two pops that cartilage loose, and that's what most people think is breaking every bone in their chest. In an elderly patient with osteoporosis whose ribs aren't as flexible, their ribs are easier to fracture. So, and then lumbar vertebra, have 5 of them. They're in the lower back. All right, and then the sacrum, and then the coccyx. Or if you're a Napoleon Dynamite fan, Uncle Rico says Grandma broke her coccyx. It's not coccyx, it's coccyx with S, like it has S's. That is the coccyx. You will hear all kinds of clinicians mispronounce that, but now you won't be one of them. But after I'd watched Napoleon Dynamite about 5 times, I started joking around saying coccyx. Guess what happened next? I'm stinking saying coccyx when I'm lecturing, so had to be careful. All right. What is the purpose of the thoracic, the thoracic cavity, those ribs? Those, number one, they provide structure, but but they also provide protection for the heart, lungs, esophagus, and great vessels. What are great vessels? We'll talk about them a lot more probably next week, I think. The great vessels are the aorta and the vena cava, or vena cava for you purists, but I can't say vena cava. Sounds like a drink, and I don't want one. Those are the great vessels. Appendicular skeleton, we have joints, we have upper extremities, we have pelvis, we have lower extremities. Where bones articulate or come together, we have a joint. Some are fused joints, such as the bones in your skull. Those are fused joints. Some are semi-fused joints, like the bones in your sacrum, the bones where your sacrum and your iliac bone connect forms the sacroiliac joint, or SI joint. That's a semi-fused joint. It moves a little bit. And then ball and socket joints, those are just what it says. You have the head of your femur or the head of your humerus fits in a fossa. That's what the socket part of a ball and socket joint is, and it's lined with cartilage to form a smooth gliding surface, and it allows for all kinds of range of motion. Now, down in your thumb, you have a modified ball and socket joint. It moves around, it moves back and forth. But it doesn't have as much ball and socket movement as, say, your shoulder and your radius up there above your thumb, where your radius articulates with that carpal bone. That's a modified ball and socket joint. Not super important, other than you need to know they're there and what types. The structure of these different joints predisposes them to certain types of injuries. Hinge joint, they have flexion and extension. So stick your leg out and pull your toes up toward your knee. That is dorsal, top of the foot, dorsal flexion. Point your toes away from you as far as you can. That's dorsal extension. Dorsal flexion, dorsal extension. That's important in patient assessment. We'll teach you about it in lab. All right. These are the pieces, parts of the upper extremities. Scapula, that big flat bone on the back side of your shoulder girdle. If somebody has a fractured scapula, that flat bone is hard to fracture. It takes an extreme amount of force, so we're really worried about internal injuries in that. Okay, remember anatomic position, radius is on the lateral side, which would be the thumb side, and your pinky finger, or fifth finger now, it's your fifth finger, not your pinky finger anymore. It is on the medial side. So, okay, that is the hand. That's the bones that make up the hand. These carpal bones, I can't remember the names of them anymore, but the way you remember them is never lower Tilly's pants, grandma might come home. That is the carpal bones. Anything you could do like that, little memory tricks to help you learn stuff, make your own up. That one that I just used was one that my anatomy professor used, and my doctor friends tell me that in medical school they use the same acronym. So come up with whatever works for you. I don't know, maybe you don't want to say never lower Tilly's pants, grandma might come home, so use biblical names and say Nathan Levi, oh, who's a T? Thomas, Paul for P, I don't know. All right, metacarpals, those bones that make up your palm, those are metacarpals, and then your phalanges are your fingers. Pelvis has multiple bones that come together to form that pelvic girdle. You have two of each. There's symmetry. Two pubic bones. That's down there midline, where anteriorly is where you can palpate it, where the two sides of the pelvis come together. There's cartilage there that hold and ligaments that hold that together, and that's the pubic symphysis, where the two come together. Your ischium or ischii, I guess, would be plural. That's those bony things that you're sitting on right now. And then your ilium is that big bone that comes up, that it's one of the largest bones in the body. I think that's the biggest bone in the pelvic girdle. And it's iliac crest. That's important for us as a landmark. So that would be coming up your side. Feel that bony thing, the big bony thing that wraps around. The very top of that's the iliac crest. That will become important. There's a picture of it now that I've just been talking about it. Oh man, what is this? Have vena cava and aorta. What are those? We're going to call those great vessels now. We see those great vessels here. And then when they get to the pelvis, you have a bifurcation, or it divides in two. And the descending aorta, it divides into the, that's the iliac artery, I believe. I'm not going to make you memorize them. I just spaced out on it, so not a big deal. But what do we call them? We call them the femoral artery and femoral vein, even though that's not technically what their name is. What's important about this femoral artery? That's where we're going to feel for a femoral pulse, right? Okay, that's important. There's that pubic symphysis I was talking about. There's the coccyx. There's the sacrum. There's that ilium. As I said, you're sitting on your ischium. And then you have the socket portion of that ball and socket, also called an acetabulum. Not super important in our world, but that's what it is. Femur, this is a biggie. This is important for us in our world. It is the largest bone in the body. When bones are fractured, they bleed. And with a patient who has a femur fracture, they break their thigh bone, we're going to automatically count that as if our patient has lost a liter of blood. Some books even stretch that up to 1.5 liters. Your book calls it a liter. Average adult male has roughly 6 liters of blood. Fractured femur, if we're going to call that a liter, fractured femur, we're going to treat that patient as if they've lost 1/6 of their total circulating blood volume. That's a big deal, right? Well, let's make it a bigger deal. Fractured both femurs. That is 1/3 of the total circulating blood volume in that imaginary person with 6 liters of blood. We're going to learn in a few weeks that the body can compensate for blood loss of up to rapid blood loss of up to 20%. The mechanisms that the body has to help play defense against that blood loss and maintain hemostasis, keeping blood circulation the same, and homeostasis, up to 20%, the body can adjust for and deal with it. Above that, rapid blood loss of more than 20%, then that patient can go into decompensated shock really quickly and end up dying on you. So it's very important to recognize how much blood loss goes with those fractured femurs. Treat your patient accordingly. Enough of that. We're not going to teach the whole course today, but I want to show you how this is important and why it's important to know these things. Okay. You don't have a kneecap anymore. You have a patella. Don't have a shin bone anymore. It's a tibia. Fibula is to the lateral side of the tibia. It's hard to have an isolated fibula fracture, except for with a side impact, like a helmet in football, shoulder in football, bumper of a car with a motorcycle or bicycle collision, kick from the side in karate, those kinds of things. Ankle, that's a hinge joint that allows flexion and extension. We already have talked about how that's important in patient assessment. If they have good, strong, equal dorsal flexion and dorsal extension, then things are looking pretty good in evaluating the lower extremities and strength in the lower extremities. Well, there's never until the navicular and the talus. There's the C, come home. And then the calcaneus is the heel bone. Fractured calcaneus is a great big deal. The force that it takes to fracture that heel bone, if you have say a fall from a height, landing on the heel, and it fractures that calcaneus, and then that energy travels up the tibia and it moves up the femur and it goes straight up through the pelvic girdle and right into the lumbar spine, and it can cause compression fractures of the lumbar spine. So these things all work together. They're important, and the pathophysiology of the injury to one part can cause significant injury to another part. So those are things that you will learn that go together, and we call those mechanisms of injury and how those work together. Function of the skeleton gives us our human shape. Some of us have a more round human shape. That doesn't have to do with my bones. It has to do with cheeseburgers and enchiladas and all that cool stuff that I love. Protects fragile organs. So that I was talking about the liver there in the right upper quadrant. That liver doesn't go unprotected. That inferior or lower portion of the rib cage covers most of the liver and helps protect it. But if we have a patient who has blunt force trauma to the right lower rib cage, we may be dealing with somebody who has liver injury. Allow for movement, stores calcium. That's very important. Very important in our cardiac physiology, even that our bones store calcium. Not get too into that today. And then red blood cells are created in bone marrow. Gives us our form, gives us our upright posture, allows for movement, protects vital organs. Now let's go through muscles, and then we'll take a break. Have 3 different types of muscles, and I'm not talking like strong ones, weak ones, and mediocre ones. We have striated muscle or skeletal muscle that is involved in voluntary movement. So when I pop up my big old bulging bicep here for you, I'm glad you can't see this. Good Lord, it'd be horrible. When I pop up that big old bulging bicep, I use skeletal muscle, also called striated muscle. See how it's like strands? Use that, and that's voluntary muscle. I have conscious control over that. Smooth muscle. Where in the heck do we have smooth muscle? You see, it doesn't have those bands, those straight bands that can contract and do work. That's what we call it when muscles contract to cause things to happen. We call that work. smooth muscle is our intestines, and another place we have smooth muscle is around our arteries, and that smooth muscle can contract and relax it to help maintain perfusion or to help move the proper amount of blood around, try to keep oxygen and nutrients going to our brain. When I say perfusion, I mean transporting oxygen and nutrients to tissue in the body. Then we have cardiac muscle. Cardiac muscle is cool stuff. Do we have conscious control over it? No. There are a couple of things we could do to maybe lower our heart rate, like bear down really hard, like we're going to have a bowel movement called a Valsalva movement. That engages and triggers the vagus nerve, and it can cause the heart rate to slow down. But other than doing stuff like that, we don't have direct conscious control over our hearts. So cardiac muscle, why do I say it's a special, unique type of muscle? Every cell in the myocardium is the heart muscle. It's made up of these unique cells. They possess what's called automaticity. Auto meaning on its own. Each one of those cells can take over and pace the heart if the normal pacing system fails. Okay. I'm not going to make you memorize all those. There are important ones that you need to know. We'll be talking specifically about those as we go along. All right. Moving on past that, we've talked about contraction and relaxation being used to do work or generate movement. A byproduct of that movement or work is heat. When is that important? Anybody ever been so cold that you shiver? Your body, your core body temperature has dropped to the point that your body needs to protect itself because it operates in a fairly narrow range. So what happens? The brain triggers a response, which is shivering, and skeletal muscle contracts and relax rapidly, and that's what makes shivering. And the byproduct of that is heat, and that's your body's using that to raise the core body temperature. If you're outside working hard in the hot sun on a 102-degree day, you don't need to shiver because your work that you're doing is raising your body temperature. And we've all experienced that. Believe it or not, I worked once. But out there working, your body has to use other compensatory mechanisms or other means of trying to lower that temperature. So we do things like sweat, breathe faster, try to radiate heat away from ourselves to cool us down. All right, let's take 5 minutes. We'll come back and hit the respiratory system. We have 3 more body systems, and then I'll wrap it up, and Nicole will take it from there. So let's take 5, unless anybody has any questions. Anybody have a question so far? Okay. Respiratory system, extremely important. Anatomy-wise, we're going to divide our upper airway at our larynx. What is that? The voice box, Adam's apple. Guys, that is the larynx is where your vocal cords are. That divides the upper airway, everything above that. So that would be so your pharynx is like there at the back of your throat, where you breathe and air goes through your pharynx and down to your larynx, and that is upper airway. Through that becomes the trachea, that's lower airway. You have 2 types of pharynx, you have nasopharynx, so that when you breathe through your nose, assuming I could do that today, cottonwood trees are cottoning in my neighborhood, and that's why my voice is all jacked up this morning. Nasopharynx, breathe in through your nose, and it makes it to the same place, to the pharynx, the same place that air you breathe through your mouth ends up in your pharynx. Posterior pharynx would be the back of your throat, and through the trachea. The first division, the carina is right there. That's where the end of the trachea, where it divides into your right bronchus and your left bronchus. And then that keeps dividing, kind of like holding up, what do you call that stuff? Oh, good grief. It's broccoli. It's kind of like holding broccoli upside down, and how that branches down and down and down. It keeps dividing and branching out, moving down toward the little bitty fine pieces. At the end, all these little divisions in the lower airway end up at the alveoli. That's where the magic happens. That's where oxygen moves into the bloodstream and carbon dioxide moves out. All right. Upper airway, nose, mouth, tongue, jaw, larynx. We've already talked about those. Nasopharynx, oropharynx, and laryngopharynx. Laryngopharynx would be the upper airway just above the vocal cords, right? Trachea, important little thing. When you swallow, because we can agree that air that we breathe in, as well as water we drink, food we eat, it all starts off going down that oropharynx, right? So far, so good. But we don't want, or at least I don't want, Diet Dr. Pepper or tortilla chips in my lungs. I'm just allergic to that. So how does our body prevent the foods we ingest and the liquids we drink from going into the trachea and then down into the bronchi and down to the point that it's just too small for the little molecules of liquid or food to continue deeper? There's a little muscular flap called the epiglottis. When we swallow, that muscular contraction that combines for the physical activity of swallowing, when that process happens, that little muscular flap folds over the larynx, folds over the vocal cords, and blocks that, so that food or that liquid makes its way down the other tube, the food tube, the water tube called the esophagus. So any of us ever swallowed something so that it went down the wrong pipe? That's what my grandma always said. I went down the wrong pipe. But you got some liquid or food down to the point that it made it past the epiglottis, and it triggered gag reflex, cough reflex down at the larynx. Thyroid cartilage, that is the big bony, it's not bone, it's cartilage, but the big hard structure that is the upper part of the Adam's apple. And then just below it is cricoid cartilage. The two have a cool little thing right between the thyroid cartilage and the cricoid cartilage is a cricothyroid membrane. Come back for advanced EMT school. One of us, or all of us, will teach you to take a scalpel, make an incision in the neck, pop a hole through that cricothyroid membrane and insert a tube in there so you can ventilate your patient who has a crushed face and a mangled upper airway so that you can't get down to the lower airway. We can cut a hole in their neck to save their lives. I think we should manage all airways other than mine that way. We should cut a hole in everybody's neck. Again, my phone didn't ring. Nobody asked me what I think. And I don't really think that. I'm just trying to be entertaining because this is dry stuff on this PowerPoint, right? Trachea, it starts at the larynx and it extends to the carina where it divides into the right and left bronchus. The right main stem bronchus is shorter and straighter than the left. The left makes a pretty sharp turn right there at the carina. So if somebody aspirates or sucks something down into their lower airway, it's likely to lodge in that right main stem bronchus if it makes it that deep. Okay. What holds the lungs in place? Trachea in part, the arteries and veins, and then there's pulmonary ligaments that hold those lungs in place. Lungs are divided into lobes. The right one has 3, upper, middle, and lower. There's something occupying part of the space on the left side, so you only have an upper and lower because that middle lobe space on the left is occupied with the heart. We look at these things in these diagrams and we think about them, these organs and all these structures inside the body. You kind of think they're all spread out and they're all, oh, I got a heart over here and I've got a lung over here. It is all really compact. If you've ever cleaned a rabbit or cut open and cleaned any kind of animal, you see how all that stuff is crammed in there in a tight space. There's not big old hollow spaces between structures and organs in there. All right, what is the function of bronchi, bronchioles, and alveoli? They allow for the movement of ambient air, or it could even be oxygenated air because we're using an oxygen delivery system for our patients. But air that is inhaled makes its way down through the bronchi, the bronchioles, and eventually down to the alveoli. And the purpose of that is gas exchange. I'll talk more about that in a second. I don't want to get too far ahead of myself. We don't want the lungs to have a hole rubbed in them by sliding on the inside part of the thoracic cavity or chest cavity. So we have some cool stuff. We have parietal pleura that lines the thoracic cavity, and then stuck to the surface of the lungs is visceral pleura, and there's a little bit of pleural fluid between the parietal pleura and the visceral pleura, and that forms a smooth gliding surface as the lungs inflate and deflate. So we don't want to rub a hole in a lung. That gives us a whole problem that we don't want to have. Okay. Muscles that it takes to breathe. We don't suck air in, even though we say we're sucking air after we've been running or mowing the lawn and we're breathing hard. We say that we're sucking air, but we don't actively suck air. What we do is create a pressure gradient so that air with a higher pressure moves toward the area of lower pressure. So how do we do that? Our intercostal muscles, the muscles between our ribs, they contract, and our diaphragm, the dome-shaped muscle that divides our thorax from our abdomen, it contracts and flattens out. So that makes our chest go up and out, and that creates a negative pressure gradient. the pressure of the air on the outside is higher than the pressure inside the thoracic cavity, so that air moves toward that lower pressure area. That is how we breathe. We also can use some accessory muscles of breathing. The primary muscles are the diaphragm and intercostal muscles. Secondary or accessory muscles are the muscles right there above our collarbones or clavicles, our neck muscles, abdominal muscles, we contract those, and maybe even our pecs, we contract them. That's when somebody is in respiratory distress and they're fighting to try to breathe, and they're contracting those muscles to try to help make that space bigger so that we have more air moving through that pressure gradient. How do we get air out? All those muscles relax, and the pressure gradient reverses. The pressure inside the chest is greater than the pressure of the ambient air around the person, so the air moves back out. We call that ventilation, moving air in and out. Really, all you have to know about medicine to be an expert clinician, whether you're a doctor or an EMT, is air goes in and out, blood goes round and round, and something screws one of them up, you got to fix it. It's all you have to know to be an EMT. So we can just go play golf every day for the rest of this class, and then you can put that down on the final, and you wouldn't pass, and you wouldn't pass your registry. But that's the basics, right? Ventilation is the process of moving air in and out by using muscle contraction to create a pressure gradient. Respiration is gas exchange way down there in the alveoli. We have pictures of that in a minute. So how does that happen? Once we get the air down there to the alveoli, well, we don't want it to just sit there, hang out, not do anything, because it doesn't benefit our patient. It doesn't help provide perfusion or getting oxygen and nutrients to tissues. So diffusion, and I usually by this point have purchased a bottled soft drink from the machine in class, and I put that on the table in front of me. So you're gonna have to visualize this, and you have to remember what carbonated beverages do. I put that on the table in front of me, and I start to screw the lid off, and it goes psss, and it makes that hissing sound, and I get the cap off, and it bubbles and it foams. And so what's going on there? That carbonated beverage, it has carbon dioxide pumped into it to make it fizzy. Otherwise, it just sucks when you try to drink it. It tastes horrible, right? Some people like flat drinks. I don't. But so you have a higher pressure inside the bottle than you have outside in the environment, and that's trying to equalize. So you have those carbon dioxide bubbles moving out of the liquid and into the air because there's a pressure gradient. Let's take that down to the alveolar level, and you don't have to memorize these numbers. I just threw this in as a way to help you visualize it. So we get that air down in there in the capillary beds of the alveoli, where the capillaries and the venules connect, and gas exchange is going to take place there. And the partial pressure of oxygen is 104 torr, or millimeters of mercury, at the alveolar level. And then look down to venous blood. It has 40 to 50 millimeters mercury, or 40 to 50 torr. So there's a big difference in pressures there, right? So we said, with the soft drink in front of you, It fizzes because we're moving the gas from an area of higher concentration toward lower. So let's picture, take your fingertips and your thumb tip on one hand and put them together with the other right in front of you. And on one hand, you have venules. On the other side, you have capillaries. At the connection of the two, you have a pressure gradient, right? You have 100, the partial pressure of oxygen is 104, and the partial pressure of the venous blood that's deoxygenated, it's 40 to 50. So there's a pressure gradient. So that oxygen is going to move toward that lower pressure. And then as that pressure lowers, the venous blood, the deoxygenated air is going to move out of that venous blood, and you've had an exchange of gases. Now we have oxygen-rich blood to circulate to the body to perfuse it, to provide oxygen to the brain, the heart, all those organs and all the tissues. And then we have carbon dioxide moving out so that we can inhale again and bring more oxygen in. And then the same thing out in the tissues, you have the same thing taking place. You have that pressure gradient that allows oxygen from, and we're getting down to in these capillaries, those suckers are one cell wide, one blood cell wide, and hemoglobin is the part of the red blood cell that's carrying the oxygen molecules. Each hemoglobin carries 4 oxygen molecules. Get down to where that's one cell wide, and you have that pressure gradient, so that oxygen moves from that oxygenated blood into the tissue, and the deoxygenated blood moves into the venule, and then that circulates back around to the heart, to the heart, and then out to the lungs to do the same thing over and over. Hopefully that made sense. What controls all of that? The brainstem, the medulla oblongata in the brainstem, in a normally functioning body, senses, and we'll talk about abnormal in a few weeks, or next week probably. It senses, in the medulla, you have chemoreceptors that sense the pH, or the acidity, of cerebrospinal fluid, and if it's acidic, which is not where we want to be, that stimulates the medulla oblongata to increase the rate and depth of respirations. So that's how the brain and the brainstem are involved in this whole respiration process. Questions on that? It's usually easier to see your eyes in class and understand who's catching it and who isn't. I hope I communicated, going back to the beginning of today, I hope I communicated a decent enough verbal picture for you to be able to see what's going on here. Okay. Ventilation, air goes in and out, right? Rise and fall of the chest. The amount of air that goes into or out of the lungs in a single breath is tidal volume. Residual volume always stays in the lungs to keep them inflated. Anybody ever had the wind knocked out of them? Just jacking around as kids, or another kid punches you in the gut, or you get hit with a helmet or a shoulder pad playing football, somebody falls and drills you in the gut when you're playing soccer, and that compression of the abdomen forces your residual volume out of your lungs. We call that getting the wind knocked out of us. Then we guppy breathe. We're just like a fish out of water, trying to get enough air down to reestablish residual volume to keep the lungs inflated. That's important that we have residual volume. Then we have dead airspace. About 1/3 of every breath we take sits above the alveoli and it's not involved in gas exchange. So that's dead airspace. Yeah, about 1/3 of each breath. You'd think I've done this lecture before, right? So how much tidal volume do we have? You actually have to use a spirometer to measure that, but we can say, you don't have to memorize this. I just want you to get an idea of how much tidal volume somebody has in one breath. Let's say somebody weighs 220 pounds. Why do I use that? There's 2.2 pounds in a kilogram. So if we have a person who weighs 100 kilograms, they have about 7 milliliters or 7 cc's of tidal volume per kilogram. So we're talking a tidal volume of about 700 cc's. And now we got to get minute volume, because that's how we measure the amount of air that a person breathes in 1 minute's time. Well, how can we figure that out? Well, we take their respiratory rate that we count when we're doing respirations, and let's say this 100 kilogram person's respiratory rate is 10 per minute. It's a little bit low, but the math's easier. And then we have tidal volume, we said, of 700 milliliters or 700 cc's of tidal volume. So minute volume, we have 10 times 700 is 7,000, or 7 liters of tidal volume per minute. So that's what those are. I'm not going to make you memorize those amounts, but we will talk about tidal volume and minute volume as we go through the respiratory chapter, respiratory emergencies chapter. And we'll reference it through the rest of the course. So that becomes important. All right. Characteristics of breathing: normal rate and depth. Does our patient have really shallow respirations, just barely moving any air, or really deep ones where they're moving a lot of air? So what is the characteristic of the breathing? And then what is the rhythm or the pattern of inhalation and exhalation? Could be that they start breathing, take a real shallow breath, and then any musicians in here, or well, I guess all of us had to take music in school. You remember what a crescendo is? Starts low and gets really loud, and then decrescendo goes back down to the original volume. Now let's just take that same crescendo and decrescendo, and let's make that a breathing pattern so that you have really shallow respirations that get deeper and deeper and deeper until they're really, really deep. And then they get more and more shallow, back down to where they started. Then there's a long period of not breathing at all, and then start the pattern over. That tells us certain things about the body, what's going on in the body, what's going on in the brain, as we assess our patient. What I just described is Shane Stokes' respiration pattern. You'll learn when you're likely to see that and what that means by combining a couple of different chapters. But that's all it is. Then we want to auscultate or listen to breath sounds. So we want to take our stethoscope and we want to, at a minimum, auscultate the apex of each lung. So find your collarbones. Right below that, maybe an inch or two below that, would be the apex, or the very top point of each lung, the very top of the upper field or upper lobe of each lung. And if we listen there, we're going to listen to one side, then the other. We're going to compare the two sounds, and we're going to assess to determine whether what we heard is a normal breath sound or an abnormal one. You'll learn more about those later. Just know that that's how you do it. Then we want to listen at the base of each lung. So down on the side, about the going straight down from armpit level, listen down there, and you compare the two sides, and you're listening to hear if there's normal breath sounds, abnormal sounds, no sounds at all. Maybe you have a asthmatic patient who has wheezes in the upper fields and they have no breath sounds in the lower fields. That means that they have, man, they're having a bad asthma attack, and the bronchioles, those smooth muscles, are really constricted, contracted down. So we're not getting any air down in the deep lobes of the lungs. So here in a few chapters, you're going to learn about some medications that, as an EMT with the proper order from a doctor, you can administer a medication that will bronchodilate or cause those bronchioles to get bigger so that air can make it through those tubes and down to the bases of the lungs. Then we go on to look for the rise and fall movement of the chest. Is it symmetric? Do we have equal rise and fall of each size of the chest? So maybe the person maybe they've gotten stabbed in the chest and air is accumulating in that side of the chest, so that when they inhale, the air only moves into one side of the chest. They have a pneumothorax on the other side, which you'll learn about in a couple of weeks, but that air is filling up the space around the lung, compressing the lung so it can inflate. So it's important for us to, in patient assessment, look at the symmetry and the rise and fall of the chest. And then we need to look to see if it looks like a really shallow respiration or a great big deep one or a normal one in the middle. Labored breathing, you get, I'll demonstrate this in class. You can't really see me do it here. So using accessory muscles to breathe. Tripod position, that's an important sign, something we see ourselves with our patient that tells us something about their respiratory position or respiratory functioning of the respiratory system. In this case, tripod position, leaning forward with the hand on each knee, and that's trying to open up, make that thoracic cavity as large as possible to get the maximum amount of air in. Now, what's the deal there? Do they even know they're doing it? Probably not. Your natural thing is to lean forward, put your hands on your chest, trying to open up your chest so you can create that pressure gradient. And then a respiratory pattern called agonal gasps. That's when somebody's dying. They're not even exchanging air anymore. You just have some muscles, the intercostal muscles contract, and you kind of see their chest go up and down, just like we talked about in CPR class. So chest goes up and down, but they don't move any air. That's agonal gasps or agonal breathing. For some reason, I can't say gasps today, but that's okay. You know what I mean. Okay, circulatory anatomy. Have two circuits. You have your book says two circuits. I'm going to add a third, but you have systemic circulation, which is blood being circulated out to your entire body. Pulmonary circulation, that's when blood comes back to the right side of the heart, and the right ventricle, the big chamber on the right side of the heart, pumps that deoxygenated blood out to the lungs so that we can have respiration, like we just talked about, to oxygenate that blood. And then that oxygenated blood comes back to the left side of the heart, and the left ventricle pumps it out to the whole body. Pulmonary circulation going out to the lungs, going from the right side of the heart out to the lungs to be oxygenated. Then the blood comes back to the left side of the heart, and the left ventricle pumps it out to the whole body. Two circuits. I'm going to add a third. We're going to talk about coronary circulation. Your coronary arteries are the blood vessels that feed the heart muscle itself. They get oxygenated blood and nutrients to the heart muscle itself. So that is coronary circulation. And So how does the blood get there? Think back to CPR, and we stayed on your tails all the time about getting complete recoil of the chest, getting that pressure off the chest when the ventricles of the heart aren't contracting, they dilate and they sit there, they fill with blood. That's called diastole, when they relax and they're filled with blood. During diastole, there's a little duct that allows oxygenated blood to go from the aorta out into coronary circulation, and that's how your heart muscle gets oxygen and nutrients. So, and then those coronary arteries feed the heart muscle, and then the coronary veins return that deoxygenated blood back to circulate back around and be oxygenated again. Arteries are the largest vessels leading away from the heart. Why do I not say the largest vessels carrying oxygenated blood? Because your pulmonary arteries, which go away from the right side of your heart and go out to the lungs for blood to be oxygenated, those pulmonary arteries carry deoxygenated blood. That's the only arteries in the body that carry deoxygenated blood in normal functioning. Then arterioles are when the arteries branch out like a tree and they get smaller, and eventually it becomes arterioles. Then it branches again until it gets down to those capillaries that I was talking about. Eventually those capillaries are one red blood cell wide. Venules connect to capillaries. That's where the deoxygenated blood is. That's where gas exchange has taken place. And then that venous blood, or blood without oxygen, moves through veins eventually to the great vessels back to the heart. Okay. And there's a picture of it. Wow. Hopefully it's something like what I talked about. Okay. Told you. Blood goes round and round. Oh, we got O2 up here. Air goes in and out. Man, it works, doesn't it? Air goes in and out. Blood goes round and round. It's what keeps us alive. Okay, how about that heart? It is a big old muscular organ that is divided into it's two paired pumps. The cardiac septum divides it into the right side and the left side. I've been talking about that right side of the heart being the side of the heart where deoxygenated blood returns to the heart to be pumped out through the right ventricle, through the pulmonary arteries, out to the lungs to be oxygenated. Then that oxygenated blood comes back via the pulmonary veins, the only veins that carry oxygenated blood. Pulmonary veins carry the oxygenated blood back to the left atrium, that top little pump on each side of the heart. That left atrium sends that oxygenated blood, when it contracts, sends that oxygenated blood through the bicuspid valve down into the left ventricle, and then in systole, remember systolic blood pressure, systole, when the heart muscle squeezes down, those ventricles contract, that ejects blood through the aorta, and then the aorta eventually branches out all the way down to those capillaries to get that oxygenated blood out through systemic circulation, out to that pinky toe or the left earlobe, or the left ventricle has to get that blood to all those places. Talked about cardiac muscle. Oh, and how big is your heart? Take your right fist, ball it up like you're going to punch me, because my lecture is so boring and you could be playing golf, but you have to listen to me for 5 more minutes. Oh crap, class ends at 11:30. We're almost done with this. About the size of your fist is the size of your heart, and you have that specialized cardiac muscle through automaticity can take over and pace the heart. You have the right heart and the left heart that circulate blood. As I said, upper chambers are the atriums, ventricles are the lower chambers. Okay. Talked about that already. Stroke volume. Stroke volume is the amount of blood that's squeezed out of the heart in one beat. Cardiac output is the amount of blood squeezed out of the heart in 1 minute. So heart rate times stroke volume equals cardiac output. Well, that's easy, isn't it? Heart rate 60 to 100 a minute. Then we just multiply that times that stroke volume. What tool do we have in the back of an ambulance that gives us a stroke volume? We don't. We can't truly calculate cardiac output, but we can know things that change cardiac output. If you push the same amount of blood out with systole every time, and the heart rate started at 60 and now it's 100, and you still have that constant amount of stroke volume, then cardiac output just went up. Electrical conduction system. The electrical system, that's what you see captured on an EKG. That electricity that starts in the SA node, the sinoatrial node in the right atrium, it moves through the electrical conduction system of the heart, and that stimulates cardiac cells to contract, and when they contract together as a unit, that moves blood around. Spend a lot more time on that later. This is a list of some of the arteries. Coronary arteries, they feed the heart. Carotid arteries, when you get a carotid pulse right there beside the trachea, that is pumping oxygenated blood to the brain. Hepatic arteries, that goes to the liver. Renal arteries, those go to the kidneys. Mesenteric arteries go to the intestines. Okay, we already talked about the pulmonary artery, talked about arterioles. Pulse, you know what that is. That's where you have that every time the ventricle pumps or sends oxygenated blood through, if you have an artery that's close to a structure so that you can compress that artery a little bit, you can feel a pulse. Handy thing to have in our business. Good for our patients and good for us to be able to assess our patients. Spleen filters blood, just like I already said. It can be the source of massive internal bleeding. Blood composition. You have the liquid, straw-colored liquid that carries red blood cells around, erythrocytes, white blood cells, and platelets float around in that plasma. So plasma is the vehicle that carries these components. Red blood cells have hemoglobin. The hemoglobin on the red blood cell can carry 4 oxygen molecules. Could be 4 carbon monoxide molecules. So we need to know what we're dealing with based on how our patient presents or how they look when we assess them. White blood cells, that has to do with your immune system. Platelets have to do with stopping bleeding, right? Okay. Systole, that's contraction of the ventricles. Diastole is relaxation. So we get systolic blood pressure. That's the highest pressure that ventricle generates when the left ventricle contracts and ejects blood. Then when it all relaxes, that's the lowest pressure. Okay. We're almost done because Nicole needs to help you with study habits and help you with some content and preparing for your next exam. Okay. Fight or flight is sympathetic nervous system. Okay, we'll worry more about that later. I won't give you a fight or flight question. I'll draw these on the board in lab because it won't make a whole lot of sense talking about it now. Central nervous system, that's your brain and spinal cord. Peripheral nervous system is everything else. Spinal nerves come off of the spinal cord funny. It looks like those suckers come off right there around each vertebra, right? And you'd be correct if you thought that. Okay. Somatic nervous system, you have conscious control over. Autonomic, your body does its thing without you having to control it. Sympathetics, fight or flight. Parasympathetic slows it down. That's rest and digest, if you want to think of it that way. Chills your body out. Sympathetic revs it up and gets it ready to do battle or compensate for shock if you've lost blood pressure. Okay, dermis, epidermis. I'm about done. I already talked about quadrants, right? There you go. Liver, stomach. There's a little esophagus coming down. Diaphragm divides the thoracic cavity from the abdominal cavity. The predominant organ in your abdomen is your small intestine. Some food and nutrients and liquids are absorbed in the stomach. Then it moves down from the pyloric sphincter into the intestine, the small intestines, and absorb more food and nutrients and medications if you're taking medicines. More of it is absorbed there. And then at the cecum, it moves from small intestine to the large intestine. And the last 10 to 20% of nutrients and liquid is absorbed there. And then it moves its way around the waste material, fecal matter, through peristalsis. Peristalsis, the squeezing of that tubular muscle, works that stuff around, out the rectum, down the rectum, out the anus, and to the world. Okay. Okay. Talk more about that later. Urinary system, kidneys, ureters, urinary bladder, and then the urethra takes the urine from the bladder to the outside world. Obviously, this is not a male patient. Okay, and then the reproductive system. Aerobic metabolism, that is perfusing tissue with oxygenated blood, and anaerobic metabolism is when you don't have blood present. ATP is the energy that your body uses to function at the cellular level. Aerobic metabolism produces 32 ATP, 2 ATP in anaerobic metabolism. pH is the acidity or alkalinity of the blood. We'll talk more about that later. Hypoxia is low on oxygen. Hypercarbia is a high CO2 level in the blood. Talk a lot more about that later. Okay. I'm not even going to talk about that. We'll spend a whole chapter on shock. Remember, the very basic definition of shock is inadequate tissue perfusion. We will make sure you study your book. Let me know if you have any questions. I'm going to wrap it up there, and I'm going to turn the rest of this over to Nicole.